So what can we do when we identify these sorts of issues? Well, you would have heard probably of sphincteroplasty, but I want to talk about sacral neuromodulation because despite being around since the mid-1990s, with over 30 years of data and over 100,000 patients having received this treatment worldwide, it's not as widely appreciated or understood or even known that it exists as we would hope. And when I talk to my patients, I say it's very much like a cardiac pacemaker for the nerves of the bowel. First and most importantly, does it work? Well, we systematically reviewed every published surgical outcome study of sacral neuromodulation a few years ago. Here they all are, actually high quality evidence for a change for a surgical intervention, including randomized controlled trials. And if I summarize this for you, I can present two sets of data. So first up, a 50% reduction in fecal incontinence episodes. So let's just say arbitrarily, patient experiences 10 episodes of leakage a week, and we reduce that to 5. That's what we're talking about, a 50% reduction. That's important because that makes them eligible for sacral neuromodulation, as I'll come on to explain in my next slide. But then there's the holy grail of complete cure, so attaining 100% continence, and that's shown on the right column here. And what's important to note is that we have achieved 80% success rates in reducing incontinent episodes by a half, and that's preserved right out to 5 years. And of those, half, so 40% overall, will be completely continent and again preserved out to 5 years. So this is one of the most effective treatments, in fact is the most effective treatment we have for fecal incontinence in the specialist setting. What's useful about sacral neuromodulation is that it involves a test phase, so we can try this to ensure that it works, and only if the patient receives 50% reduction in incontinent episodes are they indeed eligible for a permanent implant. It's a safe procedure with as close to zero mortality as you can get from any intervention and very low morbidity, and in fact it's carried out as a day case procedure. And as I've alluded to, 80% success rates and in fact 40% cure rates, and that's preserved in the long term. Just in case your patients ask, it involves the percutaneous placement of a stimulating electrode through the sacral foramina from S2 to S4. And we determine intraoperatively which provides the best contraction, the best response, and that's where we tend to stimulate the emerging sacral spinal nerve as it emerges from the sacral foramina. And the first stage is a trial phase of 2 weeks with an externally worn battery plaque to drive this stimulating electrode. And if that does lead to a 50% reduction in episodes, patients eligible to have a permanent device implanted subcutaneously in the tissue over the buttock in the same way that a cardiac pacemaker is implanted subcutaneously over the anterior chest wall. So my fourth and final take-home message is then to persistent leakage, refer to an expert, because we have interventions that are minor, that are safe, and that are effective in 8 out of 10 patients.